Can you hear me, guys, from my microphone or microphone? Okay. Before we, the title is to present some cases or clinical cases, but before we go into the clinical cases, we will just warm up by talking a little bit about pediatric epilepsy, how to diagnose it, how to, start the basic workup and how to treat this kid that will jump into clinical cases. Now, if anybody attended my lecture, I promise you, there will be a lot of repetition, but there will be a lot of new videos you're going to see, and you're going to entertain tonight, okay? Now, one thing I want to tell you, I might get excited during my talk, and if you see me leaving the lecture, please bring me back, okay? It's very important, so I can't miss the lecture. Now, epilepsy, what do I mean by epilepsy? This is just like a basic thing. Epilepsy is two or more unprovoked seizure. Seizure is a transient hypersynchronous neuronal discharges that might be associated with clinical changes or not, okay? Now, if I show you this one, and I hope it's going to work, video, and now, if I tell you what is your spot, start, and the only diagnosis is, in this case, what would be your diagnosis? What is that? Okay, so infantile colic, paroxysmal thermic abrogates, deviation, Sandy-Fire syndrome, infantile syndrome, benign, myoclonus of infancy. 4? Bassett, what do you choose? With 4, because the lady said that? Okay. All right, so the question first, when you look at the case, you want to know, is it a seizure or not? It might not be a seizure, okay? So, the fact is that to reach to this conclusion, we first go to a history. We ask the patient, okay? Or we ask a witness or a video. Today, a family came to me from Al-Ain, in my clinic, and the mom showed me a video, and then I looked at it and I gave it back to him. And he told me, no, there's more. I told him, yes, it took me 5 seconds. So, video worth thousands of a picture, okay? Once I looked at it, I realized the patient has complex partial epilepsy. She was lip smacking, and she was, unresponsive. So then I told me, you do want to watch the whole video? I told him, no, I don't have time to watch the whole video. And your son, daughter has 1, 2, 3. And he said, no, she was on camera, and she did well, but we stopped the camera, and she started to have the seizure. I told him, surprisingly, you should have not stopped the camera because this is complex febrile seizure. So a lot of the time I ask them about video, keyboard, loss of consciousness, loss of sphincter control, pure pulling himself, post-ictal, eyes open or closed, 95%. If your eyes are closed, it is not seizure. 95. So I always ask about that. History of spacing off, history of sinus insult infection or family history. Okay? Physical exam, the cutaneous finding, look at the head circumference, Woodland exam on the patient, on the family, on the neighbors, you choose dysmorphic features and family history. Now, what do I do? Our secret weapon is the EEG. So, why do I do the EEG? Because it helps me diagnose seizure, it classifies seizure, it helps in prognosis and guided treatment. That kid is infantile spasm until proven otherwise. If I do the EEG, even if I don't see the patient, and I do the EEG, I look at the EEG, he's going to go on steroid until proven otherwise. Okay? Because it's spot diagnosis. So this is very helpful in doing the EEG. Now, we do an ictal EEG when the patient is actively seizing or interictal, between attacks. Okay? Between attacks, you can capture abnormality in 50% of cases. Okay? It's not like the allergy test that Dr. Bassett does. He catches every patient allergic. It is 50%. And if you do up to 3, you capture 85%. 15% never ever going to have any abnormal EEG unless they are actively seizing in front of your eyes or while you are doing the EEG. Now, we do brain MRI with the epilepsy protocol, thin cut from the hippocampus, then long-term EEG monitoring, video versus ambulatory, and this is, to capture the spin, we have the ambulatory at our clinic, and it can be extremely helpful. When the patient, I had a patient, she would stop and stay. You shake her, you hit her on the wall, you drag her, you pinch her, she will not move. We did the ambulatory EEG, and it turned out that it is not seizure. Down the road, she turned out to be autistic, and she was having this staring, non-epileptic stress. And then we go to the more fancy dandy stuff like spit, pit, milk. I'm not going to talk about this. We don't have them here. And if we touch this point, you better be at a tertiary center. Now, MRI, ABC. I review every patient MRI, okay? I don't trust anybody reading the MRI if I don't look at it. Just today, we did the head CT with 3D reconstitution, sagittal synostosis, frank. It cannot be more clear than this, read as normal head CT with 3D reconstitution. I looked at it, the shape is like a watermelon or Iraqi watermelon, okay? And it was completely closed, and it was read as completely normal. And I see this almost 2 or 3 times a week. So, every MRI is abnormal until proven otherwise, guilty until proven innocent. MRI is trained with its twists and turns. So if you find an abnormality, please rest if you must, but do not stop. No visa retiba. Or church. Don't stop. Because dual pathology is extremely common. Now, bias and prejudice are attitude to be kept in my hand, not attitude to be avoided. If the EEG is abnormal on the right side, you're going to have to look at the right side. Up, down, left, right, front, back. Because there must be abnormality there. Huh? Then, if I don't look at the MRI, it is not red. Every resident work with me knows that. Males and females have equal grade of force, and stay safe in the MRI, please, because if you are not very careful, this is what you're going to do. You're going to be a flying missile, okay? Now, I swear to God, I will look at every patient MRI, the whole MRI, and nothing but the MRI. You have to do that. If you don't look at it, it is not real. Wallahi, it is so many times, and today the patient complained against me, and he will take me to the court. Because I told him, get me your CD MRI to review for you for free, and I lost the CD. Then he's going to talk me to the court, you know? So from now on, I will read it and give it back to him, okay? So it's very important. Now, question number 2. Is it seizure or not? It is seizure. Is it provoked or not? Then we look at the vitamins. I'm not going to go into details into that. We're going to go to the more exciting part of the presentation. Idiopathic, 55%. Vitamins, which these ones are 45%. Now, unprovoked seizure within 24 hours of documented fever in patient age 1 month to 6 years with no previous afebrile seizure, epilepsy, and no CNS infection. Seizure is febrile seizure. Can't be at 2 months, it can be. My niece, she had a 2 months febrile seizure, okay? But not less than 1 month. After I'm not talking about the workup, okay? You can do the LB, you can do whatever you want, but it can be febrile seizure if it is 6 weeks of age. Now, I want you guys to look at this patient, and in your falcon eyes, I want you to tell me your He told him, snap your finger, and he is in Honolulu. Look at the abnormal discharge. It ended now, snap your finger. Once it stopped, he stabbed his finger. Huh? So, drug of choice for this seizure. I would go with efruxifermin, lamictal, tobramax, high-dose prednisone, Keppra, all of the above, Navi approach, observation. Nafi approach? I hope not. Basket.
I know the answers.
Okay. It's not the answer. So what do you guys going to choose? Huh? Dr. Jihan? Should the deal?
First one.
Okay, she will give for him the efruxifermin. So this is knowing the type of the seizure is very important. Then the question number 3, what type of seizure? Huh? Very important. We have focal, we have generalized, okay? Focal, it's focal, generalized, can be absence, myoclonic, akinetic, juvenile myoclonic, okay? And partial can be simple, consciousness is reserved. I met a lot of people that it is complex because the patient was having hand and leg shaking, but he's completely awake. That's simple febrile seizure. Huh? And then secondary generalized, by definition. If you have your both part of the body shaking, you should be unconscious. You cannot convince me that the patient has bilateral involvement and he's still conscious, except in one case. Okay? Now, this is the secret open. Look at it, it's normal, lovely. This is focal sharps. You see that? If you sit on it, it tears. You see? So when we do the EEG, we know that is an abnormal EEG and the patient most likely is having a seizure. Okay, Dr. Sepa? Now, generalized seizure, we have tonic, clonic, atonic, myoclonic, or absence. I'm not going to talk about this one. And if you look at the EEG, start everywhere at the same time. Okay? Now, anybody know what's that? And the one who attended my lecture before, please don't participate. What is that? Colosseum? Okay. And this is the Colosseum. Okay? And people, they used to fight here until death. Like Bassel against Alain, Bassel against Hamza, Dr. Hamza against Dr. Kithar, but one of them has to die. And when they die, really, they used to drag them through these doors. See here? But before they drag them there, they will collect their blood. Does anybody know why? I don't know what I told you my lecture before. Anybody know? Because this was used to be the drug of choice for epilepsy or the falling seconds. Luckily, we didn't do it anymore. Okay? Now, Salem witch trial, people who used it in the 16th century, this is in American Massachusetts. If you have epilepsy, they will behead you, they will burn you to death, okay? Or they will put you in the prison, or they will stone you to death because they think you are doing witchcraft. So on top of your sickness, you get punished. So you see how much people in neurology suffer. They suffered a lot. Now, treatment principle. Treat underlying etiology, establish correct seizure time, match drug to seizure time, begin with one drug to max. That's very important. Every time I find the kids on 4 or 5 medication. Every single time patient come to me, I hardly ever find a patient on high medication. And my ever known story is the kid in City Hospital. 5 medication. I don't know if Dr. Kithar remember him. 5 medication, 60 seizure a day. He was in Trileptal, 45 per kilo. They asked me because they thought that I have the magic touch. I told him, what? He is not on any of medication in the highest dose, but he has complex partial seizure. Just pump up the Trileptal. From 45 to 65 per kilo, down to 1 seizure. From 65 to 80, down to 0 seizure. And the patient has no more seizure and we wean them off all the medication. So please push to the max unless the patient has side effect. Now, based by the way, of course, use drug levels as appropriate. All the new medication, don't use drug level, please. If you want to go, refer to my lecture about therapeutic drug level monitoring in epilepsy. The old medication, just make sure the heart, the liver, and the kidney are working fine, okay? Be aware, any specification like Kebra can cause psychiatric effect. If you are counseling a patient about seizure, precaution, please put in your notes that we told them don't drive until you are fully controlled. And the reason for that, that's a lady driving a Mercedes, this guy driving his shoes, okay? And this is the real, you see, this is captured from a camera on the traffic light, okay? And all of a sudden the guy is flying, his bag is flying, and this lady, when they looked at her closer, she was in complex partial epilepsy. She was driving and she was not even recognizing that she was having a seizure. So if her neurologist did not put in his note that don't drive until you are completely controlled, you will be in big trouble. Huh? Now, facts. Misdiagnosis in epilepsy in kids, 39% of refractory epilepsy are misdiagnosed. Okay? Large population are subjected to unneeded medication with the stigmata of the disease. Epileptic and non-epileptic events in children commonly present with the drop attacks, limp or eye jerk, and abnormal posture. Okay? Last problem in the ICU, in one of the ICU, I have just encounter, the patient did a twitch, he has a cardiac problem, they loaded him with phosphinetone, he coded. When we asked the doctor, why did you load him with phosphinetone? Oh, he had a seizure. Okay. Did you do an EEG? Did you capture the event? Okay, and the patient coded. So you need to be careful when you don't throw medication left and right. And infants are very prone to non-epileptic care. Now, case number 1. Let's go for the man. And if I know you will be, you're not going to be probably happy. He's not going to do it. Okay, did you see that? All right. Question. Are you concerned? Yes? No? I can't be, I might be, I have to, I need to ask them. Who's concerned? Dr. Barry, are you concerned? She's not. Basta. You are concerned? Dr. Kitha?
Yes.
Okay, he's concerned. All right. If you are, what is next, Dr. Basta? EEG, MRI, video EEG, HCT, barium mean, all of the above, none of the above.
I would go with the video EEG.
Video EEG, yes. So we did that EEG, not the video EEG. And look at the EEG, look at the left, this is right, left, right. It looks absolutely darn normal. Remember, this is an interictal EEG. It is not during the attack, it's between that. Okay? Very convincing, lovely EEG. Dr. Kitab, do you have any concern about the EEG? I need that you're feeling from the bottom of your spleen, not the heart, even down low. Okay. Now, 60-minute EEG done, and it was normal. You interested observation, long-term video EEG to capture spill, Holter-Gunter, brain MRI, HCT. Sabah. Your chance being right is 25%, so throw it anything. Huh? Long-term EEG, good catch. Why? Because you want to capture the spill, right? Yeah. Okay. And during the spill, we did an EEG, or during the attack, and we had this EEG. Look here, and all of a sudden, it is attenuated, all right? Then you have another one here. Your only spot and start diagnosis is benign myoclonus, epilepsy of a childhood, atonic seizure, Douce syndrome, infantile spasms. Who said something? Huh? Jihan. Which one? Huh? Benign myoclonus. So that is an infantile spasm. You see how important to capture the spill? I just had a patient 2 or 3 months ago, absolutely normal interictal EEG, and when we repeat it down the road, it was very abnormal. Typical hips arrhythmia. So please, if you have a concern, give me a buzz, because we can't do the 24 hours EEG. Okay? It happened for 6 months. There is a flexor, extensor, mix. EEG shows hips arrhythmia, interictal, but not necessarily like in this case. Most frequent ictal manifestation is electrodetrimental response. It's up, boop, then it will go down. Okay? Treatment, high-dose steroid, UKIS protocol. If they have tuberous sclerosis vigabatrin and ACTH. I don't remember when was the last time I used ACTH. Always high-dose UKIS steroid. Now, this is a guy. He's sitting in a chair, all right? And this guy is looking up to the EEG, and I want you to watch what is going to happen. Getting very slow, look up. He's a 16-year-old man who started to have this attack while hooking him up to the EEG. So he was on EEG, okay? Code in act. Next step, start Kibra. You got the EEG. He was on the EEG when we got the seizure. Brain MRI, HCT, refer to a psychologist, psychiatrist, refer to a cardiologist. MRI? 1? Okay. That's it.
could be a pseudo seizure.
By the way, Basil is my classmate. We did our medical school together and we were in America together. That's why I keep hammering him. I know he's not going to get mad at me. Okay? So, which one do you want to choose, Basil, looking at the number 5? What do you want to do?
I mean, if the EEG was normal, and during the attack there was no, so this could be a pseudo seizure.
Okay.
So, pseudo seizures, we refer them to psychologists.
Excellent. So, we referred home. Your diagnosis is, I'm not going to do that, atonic seizure, atonic myoclonic, tonic-clonic, myoclonic, non-epileptic seizure, syncopal attack. Non-epileptic. Excellent. Any other thought? Okay. So the diagnosis is syncopal attack. Going back to the case, to be honest with you, to be fair with you, here there is an ECG trace running. So all of a sudden we saw a sudden stone, and this patient he had arrhythmia, and he lost the brain supply, blood-brain supply, and boom, he had an attack. And that's typical seizure with syncopal attack. So we need to consult kids' heart and cardiologist. Okay? Now, I want you to look at the seizure. If anyone gets this seizure, he will get free psychiatric consultation from me for the rest of his life.
And she seems to be.
Look at this. Flying motion. One attack. Very interesting. Extremely interesting.
Can you tell me what day was this, Tammy? Okay.
So do the best you can. Okay. Diagnosis. Non-epileptic spill. Panic attack. Seizure attack. Syncopal attack. None of the above. None of the above. Any other? Huh? It's okay, you can say it. I would have not guessed it, but I prepared the lecture, so I know what is it. Jihad. Have you ever seen such stuff in Libya? Have you ever seen such stuff in Libya? Okay, so you are excused. So, what do you want to do? Who would go for non-epileptic? Perfect. Who would go for syncopal attack? Please, no. She was lying down, okay? Now, this is confusing. Okay, so in this case, remember, she had bilateral involvement, and she was still awake. And we said in the lecture, if you have bilateral involvement and you are still awake, there is only one seizure that causes it. And that's the only one seizure. It's called supplementary motor cortex seizure. So basically, you are affected here, it's a kind of simple partial seizure, and you can have bilateral involvement, okay, and you are still awake. So that's why I gave you a lifeline consultation. Now, let's go to the next. That's a kid, 6-month-old. Dr. Jihad saw him in the pediatric floor, and Dr. Saba told here, yeah, referring to Dr. Hamza, this kid, is not looking good. Did you see what he's doing?
Okay.
And God is very happy. I can't believe that.
Are you okay? You just had a seizure.
She don't need diagnosis.
No. Want to bite something else? Want to bite something else?
Okay. You saw that, right? You're going to have to wait for the second one. That did that, huh? I'm going to do the try.
Here you go.
So that, bastard. Next step, EEG, ECG, value ECG, the slides. Don't tell MRI, no valve. EEG. Does anybody object? Is that exchange? You okay with that? Alright. So we did the EEG. The EEG done and was normal next step. Value ECG, MRI, ultra-monitor reassurance, and a la casa aula. This will go home on Spanish. Bury me, Sabah. I'll give you a second chance. Okay, so we did the EEG, and what What's the spot diagnosis? Spot and only and start diagnosis is, if you get it, you get psychiatric medication for the rest of your life free. This is paroxysmal upgaze deviation of infancy. Cocktail. Benign paroxysmal upward deviation, upgaze deviation of infancy. They do like this, then they come back. They do like this, and they come back. What is the other syndrome that might look like that? No, Giovanni syndrome. Eyelid micro. But these are very rare. But this is, I have seen quite a few cases, is benign upgaze deviation of infancy. Okay? Now, let's go next. I want you to look at this one. And listen, you're going to have to see this one. And I want you to listen.
Show us what the spells, look like. I mean, is it possible for you to have one of those spells? Okay, I think you said that if I just say go, then the spell will occur. Is that right? Okay. Okay. Go.
Let's go start. We'll do it again. So this is so important.
Show us what the spell. Go. Can you stop it? Okay, so, all right. Okay, now go ahead and have a seat.
Did you see that? Now diagnosis, on-off dystonia. Cobra posture. So do like this, huh? Frontal lobe seizure, aesthesia, abasia, non-epileptic seizure, fish in attack syndrome. I'm not kidding. This is an option I'm giving to you. Really? She was like a fish in a tank. She did the cobra position. See? Now you have the excuse to do that. Fast. What do you use? Fish in a tank syndrome. Dr. Kitab, I did not have any today. You know you are close to my house, so what do you think? Number 5? Korea? But it's not an option here. We're going to stick with this one. Dystonia or not dystonia? Okay, because you told her, go, she went, stop, she stopped, right? Very smart. Okay. Now, anybody know what's aesthesia abasia? Okay, we'll talk about this later. All right. So this is called non-epileptic seizure. Because you told her go, and she went, and she was doing all these funny things. This is fish and attack syndrome, on-off dystonia, cobra position. I made this up to be honest with you, just to entertain you. But there's nothing like this. Because what she had is she's completely aware. Go, do it, stop, stop. No seizure would cause this, okay? Now, this guy, 17 years old man, okay? At the middle of the night, he would adopt this posture all of a sudden. As if he was kicking a soccer ball. Did you see that? Alright, he was sleeping, remember, so he's not faking that. All of a sudden, he got this position, leg in the sky. Your diagnosis: nightmare, night terror, kinesthetic dyskinesia, non-kinesthetic dyskinesia, non-epileptic seizure, seizure. Non-epileptic. He was sleeping, all of a sudden wake up, non-epileptic. Good.
Night terror.
Night terror, excellent bastard. So these are anyone else? Okay. Let me see if I have something written after that. Okay. That is a seizure called frontal lobe epilepsy. All of a sudden, they wake in the night and they do these abnormal posturing, okay? Or they do all bizarre things out of sleep. I have a patient who wake up at night and start shouting, and he's like shouting to the extent he lost his voice. So that's a frontal lobe epilepsy. not neurological cycle now. Okay. Now, 18-year-old man with attacks of loss of consciousness as per his map, followed by this abnormal gait.
This patient demonstrates several features of the psychogenic gait. The first thing to note,
don't believe the guy. I will not believe him. So you see this guy? He's doing all kinds of movement, side to side, up to down, front to back, head shaking. I mean, if he's a gay, we don't call he's a pretty dancer gay, but of course he's not. Now, next step, EEG. Remember, he had a history of loss of consciousness, as per his map. Okay. Then after that, he developed this attack. Okay. Video EEG, MRI, copper, and cellular plasmin, more history, or that.
All of the above.
All of the above. Perfect. Well, I will take more history. Okay? The mountain, he fell down, eyes very closed. Okay? And he was having abnormal, fatigable hip thrusting, up, front, back, right side. Okay? And head shake side to side. And then he developed this attack. You spot only diagnosis is post-ictal ataxia, post-ictal psychosis, ataxia, astasia, basal, epileptic spills for +5. Astasia, apasia. Okay, that's one line. What's the other one? Non-epileptic spells. So he had non-epileptic spells, and due to his psychogenic disorder, he developed this attack. I will be done with it. Okay? So this is called astasia, apasia. You cannot fit it in any condition, because he was walking and he was dancing. And when he was dancing, that is not typical abnormal gait. Okay, not shuffling gait, not ataxic gait, so not timid circumduction gait. So this is what's called astasia.